I think maybe we'll get started. I actually have quite a few slides. I think we'll be able to get through it in time. For those who don't know me, my name is Jason Taam. I don't know if there's any other sites that are joined in here. Can you hear us? Okay, so maybe not yet. They may join us partway through. But so those who don't know me, my name is Jason Taam. I'm the program director in anesthesia here at the University of Alberta, and my talk today is on competency-based medical education. So as you know, competency-based medical education is coming to residency programs in Canada. We're in cohort 2, and so we'll be starting this in 2017. And now part of the process is to really build the awareness and to coach staff and residents through this process and change. I do want to give credit to Carolyn Hugh, who's our assistant program director and our CBME lead. She actually created the slide deck, so I'm using her slide deck here. So a lot of the good quality stuff was her work. So let's get started. So I think this sums it up well. The saying, competency requires experience, experience requires time, but time alone does not produce experience. And so I think that traditional residency programs were set up to train our trainees in a set amount of time, and they go through rotations, and the hopes is that they become competent by the time they finish with a big exam at the end. So some of the objectives of this talk today are to discuss the rationale for changes to postgraduate medical education, to describe competency-based medical education, which I'll refer to now as CBME, as adapted by the Royal College, discuss the changes in assessment and evaluation that we're going to go through, and describe the implementation timeline here at the U of A. So why change? So we've been training residents for forever, and people go through rotations. They look after patients. They learn while they're working. They come out, they pass their certification exam, they come out, they start to practice, and many of you have gone through this program and are competent anesthesiologists looking after patients day to day with a certain level of expertise. So why change the system now? So there's a number of reasons to do this. The first one you've heard probably is the concept of the millennial learner. So, the change in mentality and attitude, which is actually a very positive thing, and I think it's a reality. Millennial learners, they are connected. They are online. They want their information immediately. They're empowered and they want to get involved. These are generalizations, but you could say that millennial learners they really enjoy working in teams. They crave clear expectations and guidelines in terms of achievement, and they are very goal oriented. And I think that's true. They do need expectations and direction, but when you give them that, they really thrive. And our current system really, I think, hasn't really adapted to this change in terms of our trainees. The other impetus for this is obviously the greater accountability. The colleges and regulatory bodies have looked to the medical profession and say, you need to show that you're evolving in terms of education and training competent physicians. And are we doing that? I think there is a bit of a lag. We haven't, medicine in general. Aside from technology and medical information, I think other areas we probably could improve on in terms of our ability to evolve, and not changing for change's sake. I think that really, in terms of how we educate our residents, we really do need to demonstrate that we are focused on patient safety and accountability and regulating our own form of education and our outcomes. The next two are technology and the rate of new medical information. Obviously, it's moving even more rapidly than it used to before. We're assimilating new information, new technology, and even greater rate. So for us to be able to keep up with that, I think we need to adapt our education system to accommodate that. And another is duty hour restrictions. Obviously, with pre-call, post-call, reduced call days. We have to maximize the amount of time that we have with the learners to optimize their learning and exposure to patients and how they get the most out of those experiences. So next I'm going to talk about some of the features of the millennial learner. So this slide has a lot of information on it, but really what I want to talk about is, up to 40% of them are, surveys have shown up to 40% of millennial learners are involved in, or want to get involved in leadership or administration. They're very empowered. There's a great deal more activism in terms of with healthcare policy and patient advocacy than there ever has been before. And as CanMed's 2015 has come out, they've changed the manager role to the leader role, and they've tried to evolve that as well in terms of some of the intrinsic skills at CanMed's to adapt to the millennial learner and some of the realities of the current education system and the medical system. Key is just taking a sec here. So another slide. So, other features of the millennial learner. I don't want to say they're distracted, but certainly, in terms of information, their ability to access information. You can see that they're on the internet an average of 27 times a day, as opposed to the early days of the internet. It used to be about 5. They unlock their smartphones up to 9 times in an hour. They won't watch a video that's longer than 4 minutes before they turn their attention to something else. And marketers and people that cater to this demographic know that they have 5 to 10 seconds to catch the attention of a millennial before they get bored and move on to something else. So, so in terms of information and their ability to focus and to assimilate, I think they really need novel and unconventional ways to really be able to learn. Other features are that they're untethered. So, in the workplace now, up to 30% of them are consider themselves mobile. So they don't work at a traditional setting in an office or space. They move everywhere and they do their work from remote sites. Another interesting fact is that up to 62% will actually invest their own time and finances to seek further development and education opportunities. So if something matters to them, they will definitely invest the time. And so I think the current education system is facing this reality, is that it's a different learner, and that the new environment really has to cater to really optimizing that educational mentality. So a couple other rationales for change. So as I mentioned, the emphasis on patient safety. So like I said, a lot of the regulatory bodies have looked at trainees and exposure to patients and the old adage, the see one, do one, teach one, that we've been using forever. Really, we really have to look at that. I mean, in terms of optimizing patient safety, optimizing the experiences that our trainees have, and how we coach them through that. Again, the practice on patients, and is our current system working? And you probably heard this term, the term failure to fail. And so, and I think that's the one sort of underlying theme you may hear with the move to competency-based education is our ability to teach and document. We sort of have a system where we are forced to determine competency in a day with a resident or a trainee or any student for that matter in an educational system. And they go through and a lot of that information is scattered. Feedback may not be timely, and then we have often not infrequently we get trainees that get to an exam, certification exam, and the hope is that they get sorted out, and that's not fair, and I don't think that that's a realistic way to train somebody. So you're gonna and I think that's one of the issues that competency-based education is trying to address. And so, and the ad hoc nature of medical education. You know, the rare cases and exposures are infrequent. They happen by chance. If you happen to be there and experience it, that's great. If you get great teaching around it, that's even better. But how often does that actually happen? And there's certain things that are life-threatening, especially in our profession, that we just don't get exposure to. But if in clinical practice you get exposure to it, you know, you need to be able to be competent to manage those scenarios. So the Royal College looked at this, and this is from their CBD slide deck, and they've mentioned a number of things. So they feel that the system needs to address changes to patient and societal needs. They need to be able to assess competence, but teach for excellence. Ensure competencies in all domains evolve across the continuum of medical education. So it says residency to retirement, and I'm going to get to that in a second, talking about the stages clamshell, and enables flexibility and allows physicians to identify when and how changes apply to practice. So how are we going to do that at the U of A, and how is anesthesia going to do that? So, you know, one is to adapt to the strengths of the millennial learner that we mentioned before. To have a deliberate and planned curriculum, clearly outline expectations and objectives. To maximize active learning opportunities. And to focus on outcomes. And so that's one thing that I'll talk a little bit about later, is about EPAs and competencies and milestones. That really is an outcome-focused way of teaching. And then more assessment for a holistic view of the learner. So the issue right now is that a lot of our current evaluation system really looks at a lot of the medical expert aspects of our training, and a lot of these intrinsic roles, the health advocate, the collaborator, professional, we sort of add on or assume implicitly that if you're a good medical expert that those other things will follow, but that's not the case. So next I'm going to talk a little bit about our current issues and our future state. There's a lot of things here that I've kind of touched on, but the two that I really want to mention are the one is the new standards in medical education around the world. So we've seen that CBDME has been adopted in other countries, and in Europe, and even here in Canada, our family medicine programs have moved to the competency-based program, and so I think it's time for the specialty programs to also look at this as well. The other is this idea of continuous learning, which I'll talk about with the Royal College diagram here. As you can see that the idea of competency-based education extends beyond residency. So once you get your certification and you're in practice, the idea is that this method of learning continues on until you retire. And so this is what I was talking about, the stages clamshell. So you can see that a number of things have been labeled differently. I'm going to touch on a little bit more detail later on. So you can see here's where you finish your medical school and you begin your residency. And you can see that the first stage is called transition to discipline, which is essentially like your PGY 1 year. Out of that, you move into foundations, which now makes up your PGY 2, 3, and 4. And then after, foundations is actually the end of PGY 1 and part of PGY 2. Core is where we would do our subspecialty rotations. So you can see that there in the middle. Just sort of get my biggest pointer to work here. And then you can notice that actually the big difference here is that the Royal College examination is right there. So it's not at the end of your training. So the idea is that actually you complete that at the end of core. You complete a component of that at the end of core, and then you go into transition to practice. So then after that, you've completed your exam, and now you can focus on completing a lot of those aspects of your training or experiences that will get you certified to become a licensed anesthesiologist. So, the idea is now you're not sprinting to the finish and then writing this big exam, and then day one, July 1st, you've got your FRCPC and you're out and practicing. So the idea now is that you complete your exam, you've demonstrated that fund of knowledge, and then you go and you further refine those clinical skills that you have. So initially, when they were creating competency-based medical education at the Royal College, this is one thing that in their documents that they said is competency-based education is an approach to preparing physicians for practice that is fundamentally oriented to graduate outcome abilities and organized around competencies derived from an analysis of societal patient needs. It de-emphasized time-based training and promises greater accountability, flexibility, and learner-centeredness. So the other thing I want to mention is, so actually before we go to that, so traditional rotations are based on time, and so you do a block of internal medicine, you do 3 blocks of ICU, and that essentially makes up your residency. Now, looking at competency-based education, we're really focusing on outcomes, and we'll talk about EPAs, which make up sort of the framework for competency-based education in residency training. So, CBME, there's a continuum of it. As you know, you've probably heard of the Toronto Orthopedics program, which was a time-free program. Residents rotated through certain specialties, subspecialties in orthopedics and surgery, and they completed these EPAs. And once they completed the EPAs, or demonstrated the competencies, whether it was 1 week or 4 weeks, they moved on to the next block. A tremendous undertaking. They had a dedicated secretary who did all the scheduling for that, and values range in terms of costs for the time-free residency was around $800,000. So you can imagine it's a tremendous amount of manpower and cost to do that. Anesthesia programs are looking at a bit of a hybrid model where we're not going to have a time-free structure, but it's time is used as a resource and as a framework as well. So there's more structure than a time-free CBME residency. And so this is just a chart showing the differences between time-free and time-dependent. Time-dependent is what we're in now, and time-free is an example of the orthopedics program at the University of Toronto. The main things that I want to point out are here is that the teacher focus and the learner focus. So you can see that the teacher role, as you go from time-dependent to time-free, supervision and direct observation. There isn't a lot of change here for the average staff that's working with residents, and I want to emphasize that it isn't something that is going to be a complete 180 to what you're doing today. And I'm going to talk a little bit more about the evaluation system towards the end. The other difference is the learner role. So obviously you can see that as we go to a time-free or a hybrid model, there's a lot more onus on the learner to take charge of their education and to ensure that they are meeting those competencies. So instead of showing up to a rotation and working through it, they need to demonstrate that they're actually attaining those EPAs and meeting those milestones. So this is the clamshell, a little bit more detailed with some more information. You can get this on the Royal College website, but essentially is what I mentioned before. So you have the transition to discipline, foundations, core, and then then you can see beyond certification, it goes on to continue professional development and transition out of practice. So the Royal College is really looking at maintaining something similar for their maintenance of certification. And then, so I'll talk a little bit more about the stages and what exactly is going to be in those stages. So transition to discipline, as mentioned, is really the first three, should be the first 3 or 4 months of residency. There should be introduction to anesthesia, plan to have simulation boot camp, and then a lot of the other aspects that we learn in PGY1, so communications and equipment, we're going to place in the transition to discipline. So the idea is that after you finish transition to discipline, you should be able to be on call and function at a certain level. And it varies from site to site, but that's the idea of transition to discipline. Foundations is the next part, so that really makes up the rest of your PGY1 and part of your PGY2, where you're doing your anesthesia year and a lot of the off-service rotations that help you get prepared for the LMCC Part 2. So your critical care, pediatrics, obstetrics, those rotations. And in some other programs across the country, they've looked at actually removing a lot of these rotations, but a lot of discussion has come up in terms of the idea of just interactions with patients and those experiences and how important they are. and not moving completely away from, say, doing obstetrics or doing surgery. Managing those patients and having those discussions with patients and families, which something in our field we don't do quite as much of compared to other specialties, but they're still very important. Core is the next part, so that's essentially your latter part of PGY 2, 3, and 4, where you do a lot of subspecialty anesthesia and you further refine your clinical anesthesia skills. And then finally, your last year is transition to practice. So it says here it's flexible duration, and so the idea is that in theory you could complete your residency in less than 5 years, and in Ottawa their program is 4 years. But that is the idea, that if you've completed all, if you met all your EPAs, you've achieved all you have a portfolio as a resident, and you've fulfilled all the parts of your portfolio, that you can actually finish your training a little bit early. We're still structured to have a 5-year program, so that isn't something that I think we're rushing towards, but certainly that's something that's part of the system. So I know that sounds a lot different in terms of what we do now, but really, I mean, it's labels, different labels for a lot of the same things that we have in terms of our transition through residency. So if you look at the old way, our junior resident year, transition to discipline, then going into foundations. Then as a senior, so R2, 3, and 4, you do your subspecialty, and then the idea is that now at the end of core is that you do your written exam. Then chief resident as PGY 5, and at some point you have your oral exam there. So you can see that they've decided to move the exam a bit earlier, and really it's a lot of relabeling in terms of the stages through our residency program. So now I'm going to get a little bit more into actually the EPAs and the milestones and what each we're kind of replacing or substituting a rotation block with modules. So you can see that in the stages of training, whether it be core, foundations, they're going to make up a series of modules. So in this case, we've written thoracics, neuroanesthesia, pediatrics. So these, instead of doing 3 blocks of peds anesthesia as a PGY 3 or 4, you're going to complete your pediatrics module, which will have a certain amount of time in pediatrics plus all the evaluation and assessment tools that go with it. And that's where the EPAs are. And I'll talk a little bit more about EPAs, which you've probably heard a lot about. EPAs are really sort of the skill that a trained anesthesiologist should be able to perform, and then that's what it describes. The milestones are the competencies that are within that. And I'll give an example of that. So I know that you've probably heard this a lot, and when I first heard it, you think Environmental Protection Agency, but a lot of these things are used quite a bit, and I think that over time you get a lot more familiar with it. So an EPA is a task in a clinical setting that may be delegated to a resident by the supervisor once sufficient competence has been demonstrated. So an example for that would be to run a pre-admission clinic. That would be an example of an EPA. ENT has, they're in cohort 1 and they've started. An example of an EPA for them would be to manage epistaxis. So that is what an EPA is. The thought was initially that our residency programs would have 20 to 25 EPAs to describe our entire training. The truth is that we've actually have a lot more EPAs than we expected. We actually have close to 90 for our entire training program. So there are a lot more EPAs than we expected, but I think that based on the work that's been done, I think it does reflect well the spectrum of work that we do. So typically EPAs integrate a number of milestones, and so there's a lot of overlap. So you can see that for example, in the running a pre-admission clinic, a milestone or a competency that would be with that would be writing appropriate insulin orders for a diabetic patient. You can see that may be in your EPA for pre-admission clinic, but it may also be in your your perioperative EPA. So there's a lot of overlap there. Milestone is an observable marker of an individual's ability along the developmental continuum, which is used for planning and teaching. So the difference between a milestone, how a milestone fits into an EPA would be that a milestone really depends on the stages of training. So if you have someone that can manage an airway, obviously that's going to vary from a senior resident to a junior resident, and what's expected of them. The key difference between an EPA and a milestone is that EPAs are tasks or activities that must be accomplished. A milestone is the ability of the individual, and so that's that's a more succinct way of describing it. Here's an example of an EPA from the Dalhousie program. As you can see, it's a management of a media-style mass. And you can see that with that there are milestones. And so as you go through your stages of training, you know the ability to manage that EPA or to work through that EPA increases in complexity. So someone who finishes medical school demonstrates understanding of respiratory anatomy and physiology that's appropriate for this, and then as you go through, obviously they have enhanced expertise. So demonstrate teaching and research in anesthesia for medial-style masses. But in transition to practice, demonstrates management of medial-style mass resection, demonstrates understanding of intraoperative and postoperative complications for a medial-style mass resection. And they've cross-referenced that with CanMed's role, so you can see medical expert. So most of them are actually in there already. And this is what the flow chart would look like. So you have a trainee that's completing their milestones. Have they completed their EPA? Have they completed the milestones to complete that EPA? Yes, then they would move on to the next one. I should say that it's not necessarily move on to the next one, but it could also mean that they're moving on to the next stage of that EPA. The other thing is also you could be working on multiple EPAs at the same time. So it's not like you're working on just one and then you move on to the next. You could be working on a number simultaneously. So if they've completed that EPA, if not, then there's the ability to look at the EPA and what are the deficiencies in terms of the milestones or competencies. Then the plan is to review those milestones and address that specific difficulty. And so I think that's a fundamental difference in terms of milestones and EPAs and how we teach on a regular basis, as opposed to what we do now in terms of the meeting expectations, exceeding expectations, inconsistently meets, and trying to make that assessment on all those skills over a course of a day. Here's another slide that just shows the differences here. So EPAs are work descriptors, competencies are person descriptors. So you can see those are typical examples of EPAs. So discharge summary, discharging a patient, resuscitation, central line. So the other thing with EPAs is that we've broken them into technical skills as well. And so then there's a second series of evaluation forms for that. And that's the other difference, is that there's a number of different evaluation forms that we're going to be using during competency-based assessment. Again, another diagram just showing the differences. So you have your old rotations, now they've become modules. Then expectations, objectives of the rotation change to EPAs and milestones. Your fighter becomes a portfolio now, because now there's a number of aspects that go in with it. So not only do you have your evaluations for intrinsic roles, but also whether you met those EPAs and any other aspects such as scholarly activity are built into that, as opposed to sort of lumping them into a fighter that we currently do now. And then the big exam at the end of PGY 5, the idea is to have this exam before you actually finish your training, so that you can, for senior residents, can actually focus on working on those clinical skills that they want to improve on, as opposed to just trying to prepare for this exam at the very end of their training. So in CBME, so the idea is to collect enough evidence, and this is where the residents' input into how they actually meet their EPAs and competencies really comes into play. You're collecting enough evidence to promote a resident, not enough evidence to fail a resident, and I think that's where it comes to the failure to fail. The issue in terms of residents struggling, they're going through their rotations, things may or may not get picked up, and in the end, instead of saying, well, did they pass, you sort of say, well, there's enough information for them to say that they didn't meet the expectation. They may have to repeat something, yes or no. And so I think that really trying to turn the way we look at teaching and assessment and feedback in a different direction, I think is really important. So what are some of the implications for assessment? So Like I said, multifaceted. So there's going to be more than one assessment method. And so typically we use our daily evaluation sheets, which is one aspect of it now. We've been transitioning over to this new sheet with new metrics. But now we're moving to a different series of assessment tools that look at other things such as clinical skills or technical skills. So for example, you saw central line in there. So that would be an example of another assessment tool where you would actually just evaluate the resident on their central line insertion technique, and that's what you would do for the day. Obstetrical epidurals would be another example. So you would observe the resident perform an obstetric epidural. And there would be an assessment form on that technique as well. And they would have to collect a certain number during a rotation in order to demonstrate that they've met that EPA. Those numbers we haven't quite determined yet, unfortunately. But I think that at this point, I think considering the number of obstetrical epidurals that we actually probably observe now, I think if we to sort of assign a number to it, I think it would probably be better than what we're doing realistically. So, the other aspect, and I talked about the involvement of the staff, is that, assessment now is more continuous and frequent. So now, observing and coaching is become much more important. Things that we do every day, or that we should be doing every day. We're really sort of focusing a little bit more on that and actually documenting what we're doing and documenting what we're observing. So the other aspect is included narrative, so things that you see and describe. And the idea of that is it's supposed to be factual. You're not supposed to make a decision on that daily encounter when you work with residents. You're just supposed to state the facts. And like I said, direct observation is essential. So, obviously there's a lot of faculty development that comes with this. Coaching, the idea of coaching learners and helping supervisors and faculty with this transition. I think that's very important and part of the change management aspect of CVME. What I'd like to say is that it's not very different from what we do from day to day right now. I think a lot of the paperwork that you're going to see is a little bit different. Hopefully not too much more than what you're dealing with on a regular basis right now. But certainly, a lot of, and so one of the best ways to describe it is that there's sort of a front office and back office part to this. So the front office part is really for clinical staff that work with residents. And the front office aspect is that there's different evaluation systems. There's a bit more assessment that you have to do. The method which you get feedback is a little bit different. The back office is all the other stuff. So talking about competency committees and academic advisors and the EPAs and how it's structured with the milestones. That's a separate entity of work that that I think that the average staff doesn't have to get too bogged down with. Certainly, as part of the awareness piece that it's important to know about. But really, that's not something that I think the average staff that's already teaching in a clinical realm that needs to get sort of inundated with. But like I said, so residents must prove competence. We can no longer assume it. So just briefly talk about some of the current problems that we have. So too few data points. So what I would say now is that during a 4-week block we have a minimum of 12 daily evaluations for the resident to submit. That takes into account post-call days, academic half day. But you can see that really you're working 20 days and you're only evaluating 12 is not really ideal. Too few direct observations. I think that we have a tendency to say let a junior resident run a room, and this happens. They work their independence and they manage cases appropriately. But do we actually observe them doing some of the aspects of the anesthetic induction, emergence, pain management, the recovery room? We may not actually observe that. We infer that they did well because everything goes well, and so I think that aspect of direct observation is very important. Often not defensible. If there was an issue and we're not present for that assessment, it's really hard to really make any comment on it. Poor reliability. So I think that we do have a lot of subjectivity in terms of our current evaluation system. One staff may think a certain technique is good, or a certain way of managing a case is done one way, and so this covers sort of spectrum anesthetic management, whereas another physician may think that you should have done it a different way, and so we want, I think in CBM you want to take into account the variations in practice, but at the same time I think we try to put that try to make it more objective and less subjective, as I mentioned, and feedback. So not authentic I think is a bit strong, but I think at times when we have to deliver criticism or something that may be negative, it's difficult to do. We may attribute it to a bad day, or it's their first day of the rotation, and so again, I think that sort of is leaning towards a lot of the subjectivity that goes into our assessments from day to day. Whereas just mentioning the facts, like had difficulty with IVs today, and that's really doesn't infer that the resident was having a bad day or was not skilled in IV starts. It's just a fact. So I think that's really important as well. Validity and reliability. So really what this points to is that we need more assessments and different types of assessments. No one method is superior to the other, and we can see that here as you go on and increase the number of time that you assess an individual in various formats. You can see that the reliability actually goes up. So I think that the key is more assessment. And so I think this is another point that I think is very important. During the course of our day, I probably mentioned this already, is that we tend to try to make a complete assessment on someone's competency on a given day when we work with them, instead of just focusing on one aspect and allowing the process to sort of go through. And this is an example. You sort of see that there's points or pixel points in a picture. As you get more points, you can kind of get an idea of what the picture is. And so this is another way of saying it. So windows of competency. So instead of trying to paint that entire picture in one day when you work with resident, the idea is to try to get a window there over that course of the day. So you observe, so their preoperative assessments. So you do that, or you do another skill over the course of the day, and over the course of the rotation, there's other staff that are going to assess other parts, and that's guided by the EPAs and milestones. But over time, you're going to get enough good pictures that you're going to determine that the resident is competent or not, as opposed to trying to make that judgment call over the course of one entire day, which I think is very difficult. So, in terms of the stakes of evaluations, obviously at the one end you have the very high stakes, so this would be your specialty exam. The other point would be sort of something that's lower stakes, so daily feedback or daily encounter. So there's a spectrum of it. I think really we're looking to increase the intermediate data points where they're not high stakes, but they do mean something, and they provide us a lot more information. In talking about the role of the supervisor, coaching versus feedback, and this is where our up to recent evaluation forms were, in terms of how you met expectations or you exceeded them or didn't meet them. I think that's difficult. You sort of say, well, you're compared to your peers, you're far below your peers, or you're on track. I think that it doesn't give a lot of information, and sometimes when actually there's an issue, it implies that you're subpar, and I think that's not necessarily fair as well. So the role of the supervisor over the course of the day is to really coach the residents, things that they need to work on. So the idea is that keep doing this, or stop doing this, or try working on. And so those are some examples of coaching and where you're guiding them to meet that competency. And you've seen this at the anchor-based assessments. We've changed them really to, and I think most of you've seen this already. So the scale is, if you had to do everything versus, in theory, you didn't have to be in the room, that the resident is completely independent. This is what they do. This is adapted from Ottawa. There's probably some fine-tuning in terms of some of the wording, but I think it's getting close to what we're actually going to use. So there's a couple of other groups that are going to be involved in CVME. So you have your supervisor from day to day, but there's also the academic advisor. So it's like a personalized coach. That would be sort of a description. Other thing is that it's separate from the mentorship program. It's a detailed review of the residents' assessments and how they're progressing through their stages of residency. So So the idea is that a resident gets assigned an academic advisor, and they guide them to meeting, to fulfilling the competencies in their EPAs and other aspects of their portfolio, which then get presented to the Competency Committee. So the Competency Committee, and this is adapted from Dalhousie and probably what a lot of programs across the country will use, really it's a promotions committee. So it'll be made up of, depending on the size of the program, 4 to 6 people, and they'll meet twice a year to determine whether the resident moves to the next level. So they review the portfolio, whether the EPA's competencies are met, as guided by the academic advisor. They would look at other things such as whether they completed their scholarly activity, as an example, professionals in portfolio, other aspects such as that, test scores, and then determine whether they move to the next stage of training. So, and this is sort of an organization chart for that. Before I go on to that, I think that's important. Is that the decision to pass whether a resident passes or not and moves to the stage is taken. A lot of the pressure off an individual supervisor to try to make that decision, or whether one bad evaluation is going to make that decision or not. Really, the information that you're collecting and coaching on a day-to-day basis goes to the Competency Committee, and they look at everything, and that's where the Windows Competency comes in. Is that they look at all the information that's put together, and then they make that decision. And so it's not something that on the day-to-day the average supervisor has to be pressured with. So wisdom of the crowd. So there's a lot of controversy associated with this. I think that you've probably heard of the concept of feed forwarding or describing sort of someone that has issues. I think that's sort of a corporate or general term as well. But the idea is that when you discuss someone's performance as a group, I think that you're more likely to uncover things that may be an issue that didn't come up previously. And so, and often they don't come up until you actually have that group discussion of all the pieces that are in front of you. So the last part I'm going to talk about is some of the actual software that's going to go with this assessment. So you've probably heard of this Royal College ePortfolio, which is what we're looking to use right now. Here is a markup of what it's supposed to look like. It's basically going to, and the idea is that ultimately it's going to take the place of our Mean Pro CME dashboard. And really, so when you start your residency, you're going to go through and actually keep this dashboard throughout your training and in your career. Here's an example of the Dalhousie one. They created theirs from scratch because they've actually started CBME this past July, so they've completed year 1. Incidentally, Ottawa is actually starting their second year of CBME, and the Rural Ontario School of Medicine has a hybrid CBME program that currently running right now as their new program. The issues that we're facing right now are privacy rights. So as you can imagine, all this information for assessment is being would be stored on Royal College servers, which does conflict with University Senate regulations in terms of housing this information. So they're working on that right now. Unfortunately, we don't know what the progress is, which does make it difficult. I just ran into Aaron Wright in the hallway actually, and he said that they're working on some agreement with the college to actually start using this. So the timeline of implementation. So you can see we're cohort 2. This might be a little bit small here, but we're right here, cohort 2. So with urology, I think general surgery, certain basic internal medicine. So we're starting in July of 2016. Cohort 1 was medical oncology and ENT, and they've already started field testing a certain number of certain aspects of CVME. They haven't gone to a full CVME rollout yet, but they're close. So for our department, what do we need to prepare? So aside from the change management part and the awareness and education, there's a recruitment of personnel. So all these aspects are important. Academic advisors, creation of the Competency Committee, and simulation is going to factor more prominently into CVME, module leads, and obviously administrative assistants. We started to implement minor changes, so the entrustment anchor-based daily evaluations, which we're working to refine, but there's a move in our direction that we're looking to continue on. Online daily evaluations, continuing faculty development, and really it's restructuring the schedule for the residents. So the other thing is also is that we're going to have two concurrent programs running at the same time. While the traditional program, and as CVME starts, that'll be a separate. I shouldn't say separate, but that'll be a different program. You can imagine it's kind of like driving on a highway that hasn't been. You're on a highway that hasn't been completed yet. But that's what we're doing right now. Is that we've started our role of CVME as we're working on the final aspects of it right now. So what can you do? So spread the word. So obviously I think that we're trying to capture as many people in the department as we can. But feel free to talk about it. Ask lots of questions. Certainly that's what myself and Carolyn, and we're here for. So any question or concern that you might have, please contact us. And I know there's going to be a lot of them. If we have faculty, try to make it out. We'll try to outreach to you. I think that's important. We're all busy. We're at the OR all day. We don't have a lot of time. So I think that trying to make learning for you and making it as simple as possible to get to, I think is very important. So I think that's definitely something we're trying to work on as well. And if you have time or the inclination, please. It says volunteer. I think if you really believe in this, I think that's something that's really important. And I think that the way education is moving now, I think it's really a great opportunity and to really participate and get involved. So summary. So it's coming. So 2017, we are going to start to roll it out, teaching a different generation of learners, focusing on outcomes, and we do need help. So that concludes my talk. The two other plugs. So next year is our accreditation. So November 2017. So any issues or any concerns, come talk to me. So we're working on that right now, and we're getting ready for this in the end of next year. So please come talk to me or Carolyn. And then the other one is the annual meeting next year. I think the theme is competency-based education. So definitely if you make it out or get some of the information with that. I think there's going to be a lot of talks on competency by design and what our residency programs across the country are doing. That's it.